seventh time I'm coming to this live workshop.
Yeah. Yeah, go.
Shall I once again?
Yeah. Rajesh, come on.
Dr. Rajesh T.S., Professor and HOD of Mysore Medical College, Mysore. This is the seventh time attending this live workshop.
Thank you, Dr. Rajesh. Welcome.
Yeah, he requires a special award. He is specially selected for it. Amen.
I'm Dr. Sudarshan Agarwal. I'm working as Assistant Professor, Department of Neurosurgery, Tirupati, sir. I'm coming first time to this. Thank you, sir.
I'm Dr. Varun Tiwari. I'm a MCH neurosurgery resident right now, sir, in Bangalore Institute of Neurosciences, Kolkata.
Please speak loud. This is the again exercise so that your throat is clear and you can keep asking questions. This faculty are for to answer your questions, right?
Myself, Dr. Rahul Yadav, orthopedic surgeon, working as an assistant professor in SGT Medical College, Pune.
I am Dr. Nasir Iqbal Kamali from Patna. I am working there as consultant at Big Apollo Spectra Hospital.
I'm Dr. Pradeep Kumar, working as Assistant Professor Neurosurgery, Nalanda Medical College, Patna. Thank you.
Hi, I'm Dr. Yatin, Assistant Professor Neurosurgery.
Good morning everyone. Myself Dr. Aditya Vashne. I am working as a assistant professor in SN Medical College, Agra. Thank you.
I, Dr. Pawan Kumar, working as a consultant neurosurgeon in the Madhubani Medical College, Bihar. This is my first time here.
I am Ajay Kaushik. I am associate consultant in AIIMS Gurgaon.
Yeah, first time or
Good morning. I'm Dr. Anthony Netikadan. I'm from Kerala. I just completed my fellowship in spine surgery last month. So now currently I'm working as a consultant in a private hospital in Kerala. I'm at Aston Med City, Kochi.
Myself, Dr. Jasdev Singh. I am working as a consultant neurosurgeon at Namashar in Punjab.
Myself, Dr. Neeraj Prasad, working in Government SIMS Super Specialty Hospital, Bilaspur, Chhattisgarh. This is my third time attending the workshop.
I am Dr. Asif Iqbal, working as a consultant neurosurgeon in Purnia, Bihar.
Hello, I am Dr. Abdul Akhil Khan. I am MCS final year resident in AIIMS Patna.
Welcome, Dr. Akhil.
I am Dr. Gautam Hanu and I am working as an assistant professor in neurosurgery, Kakinada, Andhra Pradesh.
Sir, I am Dr. Mohammad Amir, a senior resident in Department of Neurosurgery, Kakinada, Rangaraya Medical College. Sir.
Hello, good morning everybody. Good morning everybody. Myself Dr. Gaurav Sharma. I'm working as a consultant neurosurgeon in IV Hospital Punjab Nawashahar. Since I'm just doing minimal invasive and open spine surgeries, cervical, lumbar, dorsal. That's it. Thank you.
Good morning, myself Dr. Ayush Gupta. I am working as a senior registrar in Medanta, Lucknow. This is my first time coming here, and I have a special interest in spine surgery.
Good morning, everyone. So I am Ranjit Singh Chaudhary. I'm currently a fellow in Gangaram and doing spine fellowship there at FNB. So we have a 70% of work as an MIS, but endoscopic is recently which started. It's the first time I'm attending this conference. So thank you.
Good morning, everyone. My name is Dr. Vivek Yadav. I am doing my spine fellowship from AIIMS New Delhi.
Good morning, everyone. I am Dr. Deepak Kumar Baria. I am working as a consultant neurosurgeon in Apex Group of Hospitals, Rajasthan. I am attending this workshop for first time.
Good morning, everyone. I am Dr. Rakesh Mishra. I am Associate Professor in Neurosurgery Department at AIIMS Bhopal. We do open and MIS spine surgeries. Thank you, sir.
Can I sit down? Myself, Suresh Thapa. I am from Nepal. I am orthopedic and spine surgeon. Thank you.
Good morning, everyone. I'm Dr. Mohammad Shoaib. I'm working as consultant neurosurgery at Maringo Asia, Gurgaon. I have done my fellowship in minimally invasive brain and spine surgery at Jabalpur under Dr. Ashish Tandon.
Hi everybody, I'm Dr. Parombi Davide from Italy. I'm a neurosurgeon chief resident in Rome and almost pediatric neurosurgeon, and now I'm working in a spine deformity unit. We are not used to endoscopic surgery in Italy. I've only seen during my French experience, so first time in India, so thanks everybody for this opportunity.
Hi, my name is Ramanuj Kabra. I'm from Nagpur. I'm associated with SR as a SR in GMC Nagpur.
Myself, Dr. Dheeraj Pant. I am currently a consultant at a private hospital in Uttarakhand at Haldwani. This is my first time attending this conference.
Good morning, everyone. I am Dr. Chirag Bansal. I am currently working as a resident doctor in AIIMS New Delhi. Thank you.
Good morning, everyone. I'm Hemant from Bangalore. I'm chief resident at AIIMS Delhi, and we would love to learn the new techniques today. Thank you.
Good morning, everyone. I'm Dr. Vishnu, senior resident at AIIMS Delhi.
Good morning, everyone. I'm Dr. Aranraj Singh, junior resident in the Department of Neurosurgery at AIIMS Delhi.
Good morning, everyone. I am Dr. Amit Deval. I am working as a consultant neurosurgeon in GMC Haldwani, Uttarakhand.
Hello, everyone. Myself, Dr. Alok Srivastava. I am working as assistant professor at Medical College, Kanpur.
Good morning. I am Dr. Vishal. I am a senior resident at NIMANS, Bangalore.
Good morning, everyone. I'm from Japan, Dr. Yamamoto. And this is a great opportunity for me to join this kind of workshop. And I'd like to be specialized at spine surgery. Thanks.
Good morning, everyone. Myself, Dr. Manoj Kumar. I am working at TMS Jamshedpur as a neurosurgeon.
Good morning, everyone. Myself, Dr. Varshesh Shah. I am working as an assistant professor in neurosurgery, Ahmedabad, SVP Hospital, and special interest in CVJ surgeries and endoscopic surgeries.
Good morning, everyone. I am Dr. Ajay Gangwar, neurosurgery resident, IGMS Patna.
Hi, I am Dr. Narendra Motorwar, consultant neurosurgeon, Jupiter Hospital, Pune.
Good morning. Dr. Sarang Rote, consultant neurosurgeon, KM Hospital, Pune.
Thank you. Thank you. Anyone left?
Yeah.
Okay. So I think most of them are in the learning phase of endoscopy, and most of them are doing spine, mostly open, and some are doing tubular. So they are here to learn endoscopy.
Yeah. Have you noticed one thing when you were looking at the screen and you were talking? Anybody? There was a lag. when you speak and it is shown here, there was a lag of few seconds, right? I mean, that's what my observation as an endoscopic surgeon, and that's what we are here for, to understand even these small nuances in the endoscopic spine surgery. When you are working near the dura, that lag, when you see something, do something, and there is a CSF tear. Similarly, this freezing of the screen. So, I mean, this is what, like, I mean, I start my presentation with, that we have to understand each tips and tricks in endoscopic and minimal invasive spine surgery and scoliosis surgery here, so that we minimize our complications. We have delegates all over the world, I say, from Italy, from Japan, from Nepal, from Sri Lanka, and from all over the India. So welcome you all. Very good morning to one and all of you, and thanks for joining us. We are here at the brink of something extraordinary. Why I'm saying so? This is our 12th AIIMS Annual Spine Workshop. I mean, it's over the last 14 years we are doing that. This is 60th year of Department of Neurosurgery, so this celebration going all over the years, and we are celebrating that excellence of Department of Neurosurgery at All India Institute of Neurosurgery, All India Institute of Neurosciences, AIIMS. And one of the most important things, this is 54th or 55th edition of Cadaver Workshop conducted by Department of Neurosurgery for all the young delegates since its inception in 2016. And when I say it is a cadaver, program or cadaver lab with minimal nominal prices, this is the place where hope is reborn, where dreams are reshaped, and new journey begins for, as Dr. Rajesh T.S. said, it is his 7th program. He is still coming here and always ready to come here. It's a celebration of ambition, it's perseverance to learn new skills, and actually it's the celebration of human value, where we respect cadavers, we learn from them, and we apply in the young or living beings so that they suffer less. So without any further delay, I start this lamp lighting ceremony. So I request Professor S.S. Kolesov to please join the dais. Professor Shashank Kolesov is head of department neurosurgery and the chairman of the meeting, and I request Dr. Ramesh Duddamani to welcome him with the floral bouquet. Then I request Professor Kamran sir, Chief of Trauma Center, and he is an expert spine surgeon. He is an expert orthopedic spine surgeon, to join the dais, and I request Dr. Rajesh Meena to please welcome him with the floral bouquet. Then I request Dr. Professor Deepak Agrawal sir, who is the organizing secretary of this meeting, to please come on the dais, and request Dr. Surya to welcome with the floral bouquet. Then I request Professor Vijay Sharma sir to please come on the dais. He is the chief of the trauma center. Chief of the cadaver lab, and dono chief, acting chief hai. I mean, I'm not wrong. So I welcome Professor. I request Dr. Pankaj Singh to please felicitate him with the floral bouquet. I request Pankaj Singh sir to please felicitate our invited guest faculty, Professor Park. I request Pankaj Singh sir to please felicitate Professor Kolesov with the floral bouquet. And I request Dr. Shweta Kedia to please felicitate Professor Raja Kumar Deshpande with the floral bouquet. So let's start with the lamp lighting ceremony. We know like it symbolizes the dispelling the darkness and the victory of knowledge over the ignorance. So let's start the lamp lighting ceremony. I request all of the dignitaries and invited faculty to please join for the lamp lighting ceremony. By lamp lighting ceremony, we will invoke Goddess Saraswati, who is a God of knowledge. And with her blessings, we are going to start this program and the deliberations for next 4 days. So, thank you very much, sir. Like starting, officially inaugurating this program, I request Professor Deepak Agarwal, sir, who is the organizing secretary of this AIIMS Annual Spine Workshop. He is a professor of Department of Neurosurgery, innovative neurosurgeon, and his ideas that we are incorporating. So, I request you to say a few words.
Thank you, Datta. I welcome all the invited faculty, especially from abroad, and our own faculty, Professor Kale, who's the the head of our department, and Professor Kamran, who's the chief of our center, Professor Vijay, in charge of this Cadaveric center, and obviously I welcome all the participants, the hand-on participants, as well as the observers, and I think we have a very, very interesting and educative course planned for today as well as for the next few days. So thank you, and I welcome you back.
Thank you very much, sir. You don't let him speak, right? So, Dr. Vijay Sharma, I mean, he is a, I mean, to him, hips don't lie. He is a hip surgeon in Department of Trauma Surgery here. He is a national table tennis champion, to be precise. So if you want to involve yourself in the crash course in the evening, you can register your names. I can forward at Sirifort. He can give a, good crash course to you. So if at all you want. So I request him to say a few words. He is in charge of ACSST lab facility here.
Good morning, respected dignitaries, esteemed faculty members, international, national, all colleagues and all friends, delegates. On behalf of ACSST, I welcome all of you for this prestigious AIIMS Spine Workshop. Well, as far as cadaveric course is concerned, my first course was in 2007 when we did pelvic acetabular course. I am a pelvic acetabular trauma surgeon. That was AO course, and that became quite popular. Dr. Kamran was also part of it. After that, we did a lot of courses, and I feel that this kind of training is, I think, the best. I think the skills you can learn on cadavers, that is next to almost, you are almost operating in the operation theater. So this is the best kind of teaching. That is what so I congratulate Dr. Kalis, Dr. Deepak and the team for this academic program, and I appreciate the effort of faculty members who have come far off from their places just for one purpose, that is their dedication towards teaching and their dedication towards learning. Faculty, I want to tell, every course we learn something. Every course. You have only 2 minutes, so I think I still have 30 seconds. And then delegates, I think I encourage you to learn a lot, and at the end of the day, it is just for patient care, for the benefit of the patient. So there is going to be a lot of learning in the next few days. And before I go and Dr. Kamran comes, Dr. Kamran is also going to request you that thing. There is going to be feedback, because feedback is very important. It's not the positive feedback which will make us happy, but it's a critical review of everything, whatever you see. Dr. Deepak will be there, I will be there. So anything you find which we can improve upon, please comment on that. I request you on that. Thank you, and have a nice day to all of you.
Thank you very much, sir. It is his extraordinary effort. He went all the way with his effort to arrange cadavers for all of us, and we are very much thankful to you, sir.
Only arranged, not created.
No, not created. Not created, yeah, true, very true. So, Professor Kamran Farooq is the chief of JPNA Trauma Center. He is spine of trauma center, and he himself is a famous spine surgeon, and I request him to please say a few words.
Thank you, Dr. Raj. Welcome to the foreign faculties, Dr. Rajkumar. We know each other for a long time, being in spine, practically meet on almost all conferences. So I'm very happy that the Department of Neurosurgery is organizing this cadaver course, especially on spine, because it's so close to my heart. Way back in 2007-8, when Dr. Sumit Sinha, he's a neurosurgeon, he was here. So it was his brainchild. He established the cadaver lab with the help of ICMR. It was initially a project from ICMR, because it was his brainchild that he established the cadaver lab, and then we have carried it along. If we go to international courses or even across India, AO cadaver labs and all, they're very expensive. Like if you see the average cost of a cadaveric course abroad is almost $1,500 to $2,000 US dollars. So I'm very happy that we are able to impart education to the growing spine surgeons who want to learn new techniques at such nominal rates, which is very important. So, and we have a fantastic well experienced faculty whom we have invited, plus the faculty here at Department of Neurosurgery, they are all very experienced. We've been doing spine for ages, like almost, I think I've been in spine for almost like 25 years now, and faculty here is almost 20 years they have been doing, and more. Professor Kale is there. I mean, he is a famous spine surgeon. So maximize your benefit you gain. Ask them questions. Don't be shy. I mean, this is the place where you learn. This is the place you can make errors and clear your doubts. So maximize your learning from these cadaver courses. Don't be shy. Interact with the faculty. They're all there, and try to gain the maximum you can. And what happens is sometimes you feel shy that if I ask this question, what will the faculty think? What will my colleagues think? I mean, you're here for yourself. You're not here for the faculty or for your own. Don't be shy. What I would say is try to maximize the experience and wisdom of the faculty who are here, and learn from them. And especially endoscopic is a new technique which is catching up. So whatever doubts you have, try to practice as much as you can on the cadavers. And obviously day after, tomorrow and day after we have the conference, even in the lectures, you can pick up the nuances. So all the best, and thank you Deepak and Dr. Dattaraj and Professor Kale and Dr. Vijay. Vijay is, obviously looking after the cadaver lab. And like he said, whatever shortcomings we have, it's my, I'll be happy to try to improve on them the next time, because I'm in a position where I can, try to improve each time. So please give a very, I would say, critiquing or feedback how we can improve on the next time. Thank you very much, Datta.
Thank you very much, sir. As you rightly said, that cadaver outside, like when we go for outside, we pay $3,000, but here we have made it available less than $200 fee. I mean, this is very nominal. It is not a commercial activity. That's why we are very meticulous in selecting candidates so that they can act as a teacher to generations of the students. So just this is the reason. And I mean, they always support and strive hard to make this course successful. Now there is the next legion that I'm calling is he is I mean, we say the love. I mean, my heart is with you. So he's our spine. He make us straight. He is a strong behind all the department of neurosurgery over the last 30 years, and he brought us in this to center of excellence. He is the one who make us go for the best, learn new technique, as well as he keep us grounded all the time. And you will find in this conference like so many people trained by him over the last 30 years. So I call Professor Shashank S. Kale, a chairman of the meeting, and Department of Neurosurgery head to say a few words.
Professor Park, who is the president of the Korean Society of Minimally Invasive Spine Surgery, Professor Sergey, who is the president of the Russian Association of Spine Surgeons, and Professor Raja Kumar, who is the ex-president of the Minimally Invasive Spine Society of India. So we have three presidents teaching you lucky delegates for this course. I wish there was such a course when I was training. I remember the first time I had put a odontoid screw, and CT scan was rare at that time, so post-operative, the resident was supposed to show the X-ray in the morning meeting, and instead of putting the lateral film, he put the AP film, which shows that the screw is somewhere in the brainstem. You know, on a AP X-ray, odontoid screw, it looks like that. And my chairman, he just turned around and said, "You have killed this patient. What have you done? Where have you put this screw?" So that was the time I started spine surgery, where nobody knew much about what to do and how to go about. And now the things have turned around so beautifully. I hope you make the best use of the next 3 days, all the delegates. You have cadaver to practice on, you have the experts to show you how to do it, and then what that translates is better results for your patients. So the aim of this whole exercise is that your patients become better and your practice becomes better. So one thing I must mention, the team has worked very hard. Dr. Deepak Agarwal is leading the team, Dr. Datta Raj, Dr. Pankaj Singh, Dr. Shweta and Dr. Meena. Everybody has worked really hard. Congratulations to them, and I hope this legacy carries on, and this workshop should become a permanent fixture on the calendar of young trainees all over the country. That whatever you do, wherever you go, you must attend this workshop in AIIMS. That's the aim, and I hope your feedback will help us get there if we are not there. Thank you, and enjoy yourself for the next 3 days. Thank you.
Thank you very much for very insightful thoughts. We are watching him, we are hearing him personally on YouTube with lakhs of views on his videos, and people still refer before going to the surgery. And all the point he said, truly, in this workshop, we are now discussing didactic lecture, showing on cadavers. In afternoon sessions, we are working again on Sorbonne modules. Then tomorrow, for 3 days, we have live operative workshops. Then in afternoon, we are discussing mid the master session, lot of different kind of cases, complications. And in the latter part of the day, there are some dedicated lectures so that they can take from A to Z for that particular topic before we relax in the evening dinner. So I mean, just be careful, like lot of our senior faculty who look young are among you. I see Dr. Rajendra sir, Dr. Hitesh, Dr. Shweta, Dr. Surya, and they will be around here to help you. understand it. If you have any silly question like what is this is bottle, you can please shoot it out so that we understand your queries and guide you better. So I welcome all those faculty to help you, and as a formal vote of thanks, I mean, I should, as I said again, I am very thankful to all the delegates who joined in the large number with the zeal of learning, so that we can put our efforts day by day to make it better for you guys. And our invited faculty, as Professor Kolesov said, they came all over the places, from Korea, Russia, from Bangalore, and some of the faculty from Rome, they are joining tomorrow. So, I mean, thank you very much, sir, for taking your efforts and joining for all of this teaching activity. I am again thankful to the support system which provided to the lab so that you can work on it. Our sponsors like Medtronic, Bonds, and rest of the other Kalsos teams, so that they made this possible so that we conduct the workshop. My other colleague faculty, not to miss Professor Pankaj Singh, he is a very dynamic man. He is the main co-organizing secretary, but you will always find him around delegates. So, and Dr. Sachin Borkar, who could not join because of some family emergency. So I'm thankful for and rest of my all organizing team, which helped me out to create and craft this program to make it better. I again very much thankful to all my event manager team, Elbon, who provided a constant support to craft this program, and my support staff which helped Dr. Neha, Vinay, and rest of the team which helped me to conduct this program. So with this, I conclude this inaugural ceremony, and I request all of you to please join for the breakfast, and then we'll start our didactic sessions. Thank you very much. So we can do one thing, like as we are here, we can have a group picture, and then we break for the breakfast. Yeah. So faculty will join, sit in the front row. Rest of the delegates, please adjust behind.
लैपटॉप और इसी में चल जाएगा, कैसे करोगे?
मैं प्रेफर माई लैपटॉप है, वो ही वांट्स माउस, माउस इज ओके।
हेल्प कर दो।
और वो ये लगा सकते, चार्जिंग भी लगाना है मेरे को।
ठीक है,
लग जाए, लगा दो अभी, ट्रायल ले लेते।
जॉन मैक वाला वो सब निकालियो, मैक का अडाप्टर निकालियो, मैक का अडाप्टर। हाँ सर, मेरे पास मेरे पास इसी ऊपर हाँ हाँ गिरीश मैक वाला सी को इसको कहाँ लगा? मैं लगा भाई इंडियन तो है। जॉन एक बार देखियो, एक मिनट आएगा, देख आ गया, आ गया ना? लगा ये इसका तो नहीं है। अरे तूने क्या नहीं कहा? ओहो इसको पढ़नी है। इंडियन दूसरा नहीं है, मेरे मिल जाएगा वो नहीं है ना, पॉइंट है ना, ये पिन दिखाएगा जॉन, PIP ओके। ये एक्चुअली ये सिंगापुर का अडॉप्टर है। अच्छा, इसमें क्या ठीक है, बता दूं या यहाँ नहीं लगेगा, यहाँ नीचे लैपटॉप को हटा दो, लैपटॉप को लगाओ उधर पीछे।
Hello.
One more in the hand.
वो मॉड्यूल कहाँ पे? So we are 30 minutes late. Let's start the program. Hope everybody settles. So there are few instructions, please note. There are 20 minutes to talk for 40 minutes. After that, the faculty will go down to the cadaver lab, demonstrate from there. It will get relayed into this hall. As I said, you can ask simple questions, complicated question, and it is clearly, audible there. So feel free to discuss. Nobody is allowed to go into the lab. It is very small place, congested place, and only for the available spaces for delegates who are registered and faculty who are, coordinating it. So just please don't try to go to the lab because it will be not useful and they will turn you away. So those delegates who have been not registered and list not given down, please don't go to the cadaver lab. It can create a problem to you. Second thing, these lectures will go for 40 minutes and then demonstration for 75 minutes each first by Professor Park on UBE and then Professor Rajakumar Deshpande on minimal invasive TLIP. Again, it will be relayed. So till 12:30 there are common sessions, 12:30 common sessions. After that we'll break for lunch, and cadaver delegates, they will be conveyed properly about who are those delegates. Already some of you knows them, and if we add few, we'll let you know. They will go to the cadaver lab. Rest of the observers, Dr. Rajesh has created a schedule for them. Maybe around 80 delegates will be divided into 2 batches, 40 each. First 40 batch will stay here. They will be having MCQ. Other batch will rotate on 8 stations. So that is again divided into 2 batches. So you will be in station, one delegate will be rotating on 4 stations. CV junction and approaches, dorsal lumbar spine, missed relief, and subaxial spine. So you can discuss with the faculty coordinator there and solve your doubts. So overall you will go from the top to bottom from the spine. So this is for you for in the afternoon. But before we start the afternoon session, so after lunch, first Professor Kolesov will take a talk on deformity correction. He has developed a special technique, so he will take a talk on those technique about how to correct deformity, and then he'll demonstrate or explain on the model in the afternoon. After that, you will break for those activity. So this is for thing for the day. So I request Professor Park to please come over the stage and please give a lecture on lumbar endoscopic dissectomy and decompression by UB technique. Yeah, thank you. Please.
Good morning, everyone. It is my great honor, and I'm very happy to be here, including Chairman Sasanka, and I'm very grateful for AIIMS. Today, I'm here to teach you about bipolar endoscopic surgery and to tell you what is bipolar endoscopic surgery. Actually, this is a number of citations on Google links and number of groups of bipolar endoscopic surgery. It is bursting. The interest about bipolar is bursting. And you can believe me because I am a main editor of several endoscopic textbooks, including unipolar and bipolar. And I also have a lot of operations for spine surgery since 1999. Originally, I started my endoscopic surgery in unipolar and incorporated bipolar endoscopic surgery. So this is my presentation on 2000 translaminar unipolar disc removal under local anesthesia, and my presentation for the interlaminar Ph.D. Actually, I am the only person who performed the interlaminar fluoroscope guided interlaminar Ph.D. And I also published several articles for UVE. Today, I want to talk about what is UVE and what is the difference between unipolar and bipolar. So it is some stage generation, disc removal is first generation, and we can move the interbody fusion. And I have experience for intradural extramedullary tumor removal with the bipolar. So this is a big difference. This is a basic concept. As you know, unipolar has some same house. So endoscope and instrument has the same channel, same house. So there are no freedoms. But in the bipolar endoscope surgery, we can use the endoscope and the instrument has freedom. We can use it separated, so it is very, very convenient to have operations. And this is the basics. Just simply arthroscopic knee surgery. Arthroscopic knee surgery move to the spine, but in the spine there is no cavity, but knee has some joint, cartilage and capsules, so they have some space for the operation. But in the spine, we don't have space for the operation. So we have to make some space with the water press. So. And the spine also connected to the cranium. Big difference. Spine is connected to cranium, so you have to press. You know very well, microscope surgery is performed in the air. Air does not transmit to the cranium. But endoscope surgery is a water medium surgery. Water medium surgery means the pressure in the surgical field is transmitted to the cranium. So if your pressure on your surgical field is too high, it is affected to the intracranial. It makes intracranial problem. So you have to know about that. And the basic is how can you handle, how can you maintain outflow is the most important. Even you insert your instrument, the pressure of your operating field is increased. Increasing pressure sometimes helpful decrease the bleeding. So you can use how to control the pressure of fluid in the surgical field. And this video shows us in unipolar you have to expose a lot of radiations. But if you have a bipolar endoscope surgery, it is just like a microscope surgery. So you don't need to expose to radiation injury, and you can use two handles during your operations. So, but this is another concept between, this is just like, this is a unipolar. Unipolar has the same housing, but bipolar you can have some separation. So you can have many convenience. And when you become expert for endoscope surgery, you can access every place, contralateral, interlaminar approach, ipsilateral approach, one level over, one level below. If you want, you can go. Especially, I like to have a contralateral approach to preserve the facet joint. So this is the same concept. This is surgical steps for bipolar endoscope surgery. People, just like a microscope surgery, after level marking, and I like to have a separation of muscles from the laminar bone to make a surgical space. Yeah, and triangulation. Triangulation is the most important. Your instrument is always in front of your endoscope. If your instrument is behind here, you cannot find the instrument. So finding your instrument is the most important thing. All over here, so most of our we are neurosurgeon. Neurosurgeon, the triangulation is very, very difficult. So you have to exercise for a chopstick method, just like a chopstick, enclosing your eyes and try to make a chopstick like this. You have to exercise about that. Triangulation is the most typical challenging point to run the bipolar surgery. And then you can put, so it is the basics. With the water pressure, you can make a working space, just like a knee joint. And we use some saber series, so we can maintain continuously clear, and we can dress continuously. And because there are always movement of fluid, your surgical field always keep clean. It is a big advantage of bipolar endoscopic surgery. So with this technique, you can go the contralateral action route. Also, you can decompress with small keyholes, just like this. This is the action route and the traversing route. If you make a contralateral keyhole, you can decompress exiting and traversing route approach, or disc removal also. So you can do everything. So this is another concept. Maintaining outflow. Only one you have to keep in mind. Maintaining outflow keeps your optimal press or operative field and keeps your operating field clean, so you can continue your operation. So this is another expense because this drill has a suction hose. So during the drillings, every bone debris and the bloody fluid is suction out itself. So we can keep the clean, very clean and magnified surgical field. This is a big advantage of bipolar endoscopic surgery. You can control your camera and you can magnification your pathology, and you can access with different angles. So compared to unipolar, you can watch your lesion very easily and very clearly with magnified visions. And you can continue your drills for long times. So for these techniques, you have to know how to make your skin incision, because this is a bipolar, so we need a two skin incision. Because I am a right-hand surgeon, so your working port is made the right side, and another skin incision for the endoscope is the left side, so making like this. So our operation is always like this. So we have to make skin incision, especially for the working port, is most important. This is a skin incision for laminectomy or ULBD. So usually lateral recess. Lateral recess is the deepest area and the most dangerous area. So you have to make your skin incision over the lateral recess. It means your calcium punch is just like perpendicular. Do you understand? If you make your skin more below this angle, you cannot remove, you cannot decompress the lateral recess. So making your calcium punch vertical is very important. So that's why your skin incision is always here, over the lateral recess. You can make 1.5 cm skin incisions. There are two types of skin incisions. One is a transverse, that's just like a transverse skin incisions. The other is a vertical incisions. I recommend for beginners is vertical is more good because you can easily transconvert the open surgery. But I like to have a transverse skin incision for the cosmetic, and the transverse is more good for the outflow. And the other skin incision is for the endoscope. The other one is an endoscope. You have to about 2 cm apart. 2 cm quarterly or 3 cm quarterly, you can make an endoscopic port. If your endoscopic port is too close, you have some fightings. But distance, you can have operation very easily. Remember it. So make skin incision apart from 2 cm, also important things. And you have to know the basic dynamics of water fluid movement. So optimal press. We have to know, we are neurosurgeons, so we know very well how is it. Our intracranial press is 5 to 15 milli HC. So if your press, surgical field is over the 30, 50, this press is transmitted to intracranial. It makes some problem. So maintaining your surgical field around 15 millimeter HCG is optimal press. So good for a good maintenance of good outflow, we need some cannulated trochas. This trochas will help you maintaining the outflows. And also this is an endoscope, so we can see only in front of endoscope, but your instrument is behind here, you can hurt your nerve. So always having operation, when your instrument come back, your endoscope also come back, and the put here also following. Also, your instrument is always in front of endoscope like this. It is most important. When you like this, you can hurt the cord or neck nerve. It just become dangerous. So this is images for about instruments. Just you can use the same instrument for a microscope. So our bipolar surgery, the instrument is small and thick. This is a bipolar. But unipolar endoscope is long and slim, so easy breakable. You can use every types of drills which is used some microscope surgery, and every types of punch you can use. And the other advantage for bipolar is we can use the radiation, RF. This is radio frequency is very helpful and very superior compared to unipolar systems. There are a lot of types of tips, and you also to know the ball tips is useful for the bleeding control over the dura. With the use of pinpoint tips, we can control the epidural bleeding also. This is some picture for the types of, this is a transperineal unipolar endoscope, and this is a bipolar, and this is some large working channel intralaminar endoscopes. There are 3 types of endoscope, as we know. So this is some, and also here we have to know the endoscope. We are neurosurgeon, and zero degree endoscope is more easy to handle. But orthopedic surgeon is familiar with the 30 degree. They like to use 30 degree. So you can see here is a light source. This the camera. And the ball tips like this. So your vision always very clear if you maintain the good outflow, and you can use several types of curettes or other things. This is the visions, And I'm talking about surgical anatomy. You have to know there is no attachment between muscles and lamina. You know very well the attachment of muscles and the bone, we need a ligament, tendons. But between lamina bone and muscle, there's no tendons. It means no attachment. So you can make space, you are offering space very easily with optimal water press. So. And use some positions. You have to know this concepts, triangulation. If you are, this is a camera, okay? This is a camera. Your instrument is always in front of a camera. If your camera is behind, if your instrument is behind of a camera, you cannot find your instrument forever. So you are looking for your instrument for 1 hour and give up your operation. So that's why you always exercise the chopstick method. When you're familiar with this chopstick method, closing your eye, you can find your instrument with endoscope like this. So, and it is also important concept because bloody water, uniform bloody water is backward outflow of bloody water for the endoscope. Unipolar, the endoscope is here. Bipolar, we have another port. So blood is washed out outside against the camera. So compared to unipolar, bipolar, the field of surgical field is much more clear compared to unipolar. That's why this bloody fluid is toward the endoscope. It is unipolar. But bipolar, we have another port. So bloody water fluid is away from endoscope. That's why bipolar is more clear. You can make clear visions. And also, this is a power of RF systems. And finally I will show you some videos. This is, I like to have a contralateral approach after making keyholes. As I explained to you, this ball has suction holes. So during drill, this drill self-suctions, including bone debris and the bloody fluid. So we can keep out the surgical field clean. And yeah, like this. I'll show you the drillings. Just before I show you again. Okay, it is the same. That's why our vision, so I'm here to explain how to make skin incisions. I'm making transverse skin incision on right side because you are right-hand surgeon over the lateral recess. Please remember it. And I'm doing the palpating the interlaminar. Yeah, this is like this. You can palpate the interlaminar space here. Because every nerve is under the bone. If you palpate the bone, your nerve is safe, always safe. I'm palpating interlaminar space here. And I'm making another skin incision about 2 cm caudal, cranial. If the distance is too close, there are some fighting between right and both hands. So keeping the distance about 2 cm is very, very important. And then I told you, make a triangulation. Making triangulation over the lamina is very, very important. Making triangulation not in the muscle. Please make a triangulation over the lamina, especially for spinolaminar junctions. Yeah. And I'm putting the trocar. This is for the left side endoscope trocar. And you have to dilate the working port for a good maintenance of outflow. So you have to separate the fascia. Fascia is some barrier for a good outflow. So you have to separate the fascia about 1.5 cms. And then screw up again your interlaminar space. And then you can change your trochus. Yeah. Because we have to one chamber. Beginners make a two chamber, right side chamber, left side chamber, and there are wall. You cannot meet. Under the muscle, you have to one chamber, just like a knee joint is one chamber. So input is a fluid input, outflow. Okay, make a patterns is the most important. And I'm putting the you can insert the RF system. This is RF systems. You can clean up the facet joint, the lamina, and then you can continue your drillings like this. Today you have to learn from me how to do. It is my duty and my responsibility for it. Yeah, and you can do contralateral decompression, disc removal, everything you can do as you have been in microscope. It's the same, everything is the same. This is my live surgery. When you become expert, I have 2, 3, 4, 5, 2 levels severe spinal canal stenosis. This is my live surgery. I can decompress the 2 level within 45 minutes. Now I can start. You can hear. Starting making triangulation, as I told you, and I am touching the interlaminar space, making another skin incision. This is for endoscope. Yeah, and you can make triangulations and exposure of laminar bones. Yeah. And the drillings, 10 minutes, 12 minutes, 70 minutes, expose the dura and the separation of ligament flavum. Okay, just before I remove you can remove ligament flavum around 16 or 17. And decompression of lateralis. I like to remove ligament flavum with the angular method. This is this is ligament flavum, which is removed with one piece. And we can move to the above levels and drillings and take exposure ligament flavum. This is a 3-4 second levels. And then we can remove remove the second level ligament flavum. So this is another video because this is today. This is very important. Here is my approach for paraspinal approach. So I make a skin incision, the caudal transverse process, drawing skin incision, distal transverse process, and make a skin incision over the transverse process. Skin incision here and palpating transverse process, and then you can palpate margin over transverse process, and with these blunt tips you can dissect bony structure and make a space for your surgery. With this method, you can make your operation more easy, and you can save your operation times. I'm making space, just like a joint of a knee, making space in the spine. Yeah. And then you can make triangulation here. Make a triangulation here. This is the endoscope. Make a triangulation on the bone and fix the trochus like this. And then you can insert your endoscope. Because there are movement of fluid. You can see this is the lateral part of SAP. Clean up your surgical bony field. Exposure of tip of SAP, and margin of transverse process. And then you can perform the decompression surgery on femoral, and also remove the herniated disc, just like this. I'm removing, this is the action node, okay? And I'm removing the ruptured disc like this. Very, very clear vision. And little bleeding, because there is a movement of fluid. You can see the movement of fat tissue. It means there are good movement of fluid. So if you keep good fluid movement and optimal press, always your surgery is easy and it's become successful. Yeah. That is my talk today. Thank you so much.
Thank you very much, Professor, for very nice talk. I mean, the best part was about how to go from the surface marking to the surgery and all the tips. So any delegates has questions? What I understand, like we are all neurosurgeons, we have some orthopedic surgeon as well. We know how to operate endoscope, some basic tips and tricks that we are discussing over the years about how to handle instrument, when to cross, and when it is aligned, how we miss things. So these are the same, I mean, and these tips can help you like a crash course to start your UB practice. That's what I feel. Any delegates has any questions, please?
Actually, no need for X-ray. Before operation, I need to inject the Methylene blue on the lateral recess before operation. With the needles, Methylene blue injection, with the endoscope, I can make sure the correct levels. But if there is some confusion, only one time, just like open microscope surgery, CM X-ray, intraoperative X-ray one time.
Yeah. So we request, like whoever asks questions, like please use the mic, because this is getting recorded and will be live streamed after, so that it will be useful for you to discuss. That's just meant, like Ramesh.
Yeah, excellent talk, Professor Park. So, basic question, like if it is a simple discectomy, do you think that biportal is advantageous over a uniportal, or both are the same?
Actually, for a disc removal, you have to retract the nerve. So unifold is more convenient to retract the nerve. But we also have an endoscopic retractor. So with the endoscopic retractor, we can retract the nerve and take it out. But unifold is more easy for disc removal.
And for instrumentation, you feel biportal is much better than uniportal?
Yes. Actually, everything, including stenosis and interbody fusions, bipolar is much more superior compared to unipolar. Only unipolar is superior compared to bipolar is a transforaminal disc removal.
Thank you.
Sir, my name is Dr. Nasmi Kumali. Thank you, sir, for such a nice lecture. I have one question that we already have a technique of distendo technique we already have.
Yes.
And I am not able to judge how this technique is better or superior to distendo technique, or is there any specific advantage of uniportal or biportal technique over the previous endoscopic methods?
Actually, I know the Testango technique. Testango technique doesn't have irrigation systems, okay? But this system is an irrigation system. There is a big difference. Your camera is easily blood thinning. You have to clean up and put. But it has an irrigation system. It can keep our camera clean continuously. Yes.
How do we ensure higher velocity of water flow?
Yes.
With at a lower pressure? I mean, you have said the Bernoulli's principle.
Your case is intraoperative pressure.
Yes.
Hydrostatic press.
Yes.
How can I control?
Yeah. How do you control that?
Yeah, there are two types of press control. One is just like pump. Using pump, you can maintain the full press. And I like to use hydrostatic press. Your surgical field about 1 cm. Your table, your patient levels about 1 meter. 1 meter above your fluid bag, you can maintain. If your blood is a lot, you can transient, you can increase your height, okay? And your bleeding is decreased because the pressure is increased. So we can control the breathing control, also height
So
of
putting
press.
it at a higher height does not increase the pressure. It increases the velocity.
If your outflow is not good, you cannot continue your operation because everything is bloody. Okay, you can continue your operation. Only you can maintain the outflow. If you are maintenance of outflow is good, don't worry about press. Just if you use hydrostatic press. Do you understand?
Thank you.
May I ask a question?
Yes.
What endoscope do you prefer use, 30 degree or 0 degree?
Yes.
And do you use pump during the procedure?
Yeah. I don't like to use pump because outflow is blocked. Continuous pumping makes some intracranial press. So that's why I like to use hydrostatic press. Hydrostatic press means positional back. So even though it is outflow is blocked, it's limited. Do you understand? So safety of press, I like to have hydrostatic press instead of pump.
What about endoscope, 30 degree or
0? Usually I like to use 0 degree because I am a neurosurgeon. But when I want to do the contralateral typical area, I like to use 30 degree endoscope like this. And sometimes to make a fusion bed on the contralateral side, intradiscal, I like to use the 30 degree to make a good fusion bed. Do you understand?
Thank you.
Yeah, thank you very much. I mean, most of our queries have been handled. Professor will be again showcasing his cases, and that time also we'll be discussing, and actually we'll be showing while demonstrating how to do. So if there is any technical based queries, he will be showing whole case as a demonstration, and you can keep talking to him so that we keep on ourselves on the track, right? So thank you very much for all the queries, and thank you, Professor, for such a nice discussion. Thank you. So, for next talk, I request Professor Rajakumar Deshpande to please come on the stage and deliver his talk on minimal invasive discectomy and fusion with tubular approach. Yeah.
Good morning. I thank the Department of Neurosurgery and Spine Surgery for giving this great, wonderful forum to discuss how to simplify complex techniques. After this wonderful talk by Professor Park, it's my responsibility to make it clear to the audience why TLIF, MIS TLIF, is the go-to surgery for all spine fusions. Years ago, 2-3 decades ago, when we started doing spine fixations, we had great difficulty in understanding which technique will give an optimal result and which technique can be repeatedly performed with observable similar results. And that kind of surgery is MIS TLIF. Transforaminal lumbar interbody fusion is one of the techniques to create interbody fusion. Why you have to understand interbody fusion as a principle is, in the earlier days, fusions were done outside the vertebrae, along the transverse process or along the lamina. By placing bone graft or a cage in the intervertebral disc space, you have a larger area of bone formation as well as sharing of load in the front along with the pedicle fixation at the back. So today's talk is not theory, it's about how you practice MIS TLIF in your day-to-day patients. That's the understanding. So I'll skip all this. So obviously you should know which patient you should do fusions, MIS TLIF, 1 level, 2 level, 3 level, like that. You do all your measurements and of the patient's preoperative VAS score, what is the kind of pain he is having, what is the deficit he is having, etc. The requirement is to understand what level you are doing, and therefore you need preoperative radiographs, AP and lateral, and of course dynamic radiographs to see which of the vertebrae are actually mobile. And then you of course require MRI to know which level the patient is having problem. Depends on whether the patient is having a single level or a multi-level problem. So let's directly dive into the surgical method. So in my practice, what I do, I don't do any different Jackson table or something. It is routine prone position you do for your spine. You can have two methods of placing the support for the chest. One is parallel on either side along with the hip support, or one on the chest and one under the hip. So the skin incision is, first thing you do is you mark the midline, and then in Indian patients, because of the body, the way it is in most patients, between 3 and 4 centimeters is good. Thinner the patient, you go towards 3 centimeters lateral, or if it is a slightly obese patient, you go 3.5 or 4 or even 4.5. So the distance from the midline to the lateral depends on how much the fat is there in the body. Then you use this kind of instruments. These are called expandable retractors. Many companies make it. It's important to understand that you have these sequential dilators. Once you have the sequential dilators, like Professor Park showed, in any muscle dilation, because the dilators are the ones which separates the muscle fibers from each other, and you make a potential space in an area where there is no space. So these are the sequential dilators. The instrumentation is not huge. It is just that you have to get used to the ability to use this. Many of you are already using it. You have to learn to refine it in such a way that where you land exactly on the lamina. And many people have been using the initial pointed guide wire to land on the lamina. I have virtually stopped it for almost 2 decades. You'll use the first dilator, the second dilator, and use it in a way that to strip the muscle off the lamina. And this is what you do. You identify the level using the fluoroscopy. About an inch incision, 2.4 to 3 centimeters can be taken on the level that is marked. And then you have a stab incision on the fascia. So what I used to do initially was I used to use the first or second dilator to pierce the fascia, but that is very difficult. It bounces back. you cut the fascia and go all the way down into the muscle using the skin incision itself, and you land on the lamina. The trick is to land on the lamina, and then what you do is you utilize the quadrant retractor to land on the facet that you want. And once you land, you can use the expandable portion of the quadrant retractor to shift out. And then this is what happens. If you see here in this area, you can see that the opening is there minimum, but at the depth you can open it wider. This is a standard expand style kind of retractor that we use. And then what do? You have to see this part. So this part is very important to understand the anatomy here. I'll show it here. This will be the parts. So one thing I want you to understand in spine surgery, especially you are doing microscope, if you look into your history and your experience, there are very few diseases which will involve the parts. Diseases involves the facet, involve lamina, spinous process, vertebral body, disc space, the whole works. Okay? So there are very few diseases which will involve these parts. So identifying the parts is very important. The next thing to identify is the spino-laminar junction here, because that's where your medial limit will be. And then you mark this much of the lamina and the facet to be removed. You know, this is the inferior facet of the superior vertebra, superior articular process of the inferior vertebra. So you need to take out this much and this much. So this much you can remove the whole facet, you can extend all this here and even go contralateral depending on how much you want to do decompression of the canal at that moment. So this is very important to identify this part. In the cadaver I'll show you how it is done here, how to use a chisel or a drill, this much or accordingly this much, and how to remove the SAP up to the pedicle. In your mind's eye, you should have that the pedicle is like this. This is the pedicle here. So if you see the transverse process, just around that will be the pedicle. So in your mind's eye, if you have a pedicle in your mind, you can start chopping the bone. Why should you chop this off? Because this bone can be utilized for grafting in the intervertebral disc space. So this is how it is. You expose the facet, then you do a facetectomy, then you drill whatever the remaining portion of one or the bone you want to remove, and then you start incising the annulus. And then once the disc is done, there is a method of doing discectomy here. Unlike the usual discectomy, because you may want to align the spine, very early in our practice we used to do fusion, and as long as we had fusion we were very happy. But nowadays you want to realize there is something called sagittal balance, and if you want to avoid the other disc from getting degenerated, you must start thinking about sagittal balance, and that I'm not going to cover now because that itself is a completely different topic of how to align the spine. Sagittal balance when you are doing even a single level fusion. And therefore you remove the disc, you then place the bone, place the P cage, and then of course start looking at the trajectories. So I use this kind of bayoneted instruments. These are very useful. These are ring instruments, reverse cutting, and then the scrapers. So you can use all this to see that you have a maximal removal of disc. So if somebody were to ask you, how much disc are you removing? So some people say, I have removed the disc completely. Some people will say, I have removed the disc more than completely. Do you know how much actually you can remove in a complete disc? Even if you use the best of equipment from the posterior side, you will remove about 65%. So if you want to remove an optimal amount of disc, there is a method of intraoperatively knowing how much to remove, and that will be shown in the cadaver lab. The understanding is you start removing from the lateral aspect, go medial, and remove the disc till you see the anterior longitudinal ligament in every case. The ALL has to be seen, and then the cortical bone has to be exposed. So this is a video of the same, and you can see that we are removing all the capsule as well as the attached muscle there, and this is the idea that you have to see this part and remove this. So this is the part that I have known as the pars. Then I make either a drill mark or a chisel, and that length is what you should remove, and that will be the marking for the superior articular process. In this particular patient, this is cranial, caudal, medial, lateral. Again, cranial, caudal, medial, lateral. Once the bone has come off, okay, then you put a hook and feel the superior part of the pedicle. And if you feel that the pedicle there is still a sliver of bone, you can either chisel it or drill it off. One part that is very important to understand is the inferior articular process, if it continues, will be in the lamina below. The trick is, if you remove the upper part of the lamina a bit, then you can free the ligamentum flavum. Once the ligamentum flavum is freed here, and you cut the ligament flavum here, this whole piece of ligament flavum will come as a piece. So then you have got clearly what we call as the dura. This is the traversing nerve root. This will be the exiting nerve root. And can anybody tell me what is this triangle? Cambin's triangle. Yeah, Cambin's triangle is nicely exposed here. You can see the dura. This will be the exposed. And understand the, oh, I'm sorry. Oops. It jumped. I wanted to show the venous plexus. So this is important to understand the venous plexus here when you are doing microsurgery. When you are doing UBE, it is very easy because whatever veins are there, you just coagulate. Whereas here, sometimes you will have these veins which are quite enlarged. If you know the anatomy of the vein, it's very easy to understand. You have the longitudinal antero-internal epidural veins and the longitudinal external epidural veins. So what happens is, the veins that you get here, this particular one, the one which is anterior, you don't have to worry. The one which is external and they exit out of the foramina, this in the form of a T. You see, this is the form of a T, like this. This is the vertical and this is the horizontal kind of level. So if you coagulate here and coagulate here, you minimize bleeding. So when we were doing earlier, this anatomy was not known to me very well. So every time there is a bleeding, I will poke either some sort of hemostat, gel foam, you keep putting it there. You don't need to do that because you can easily control the bleeding, because see here, I go superior, I go inferior, and I coagulate here, and all those veins can be easily controlled. I cut off those veins and expose the disc. Then doing a discectomy, there is a very interesting way of doing. You first have to cut the disc. I don't like to use any special root retractor. My suction acts as a retractor. It's an intermittent retraction, so less danger on the nerve root. You remove the disc, but then what I do is, I try to go lateral first here. If you remove the lateral, seeing the ALL at the anterior longitudinal ligament at the depth is very easy. You keep removing, you see, you can go all the way to the ALL there. Once you go and see the ALL, you know for sure that disc in that area all the way to the ALL is removed. And then what you do is you gently retract the dura, cut a little more of the PLL, take out the disc and use reverse instruments. There are some instruments I'll show you which you can go all the way across. So this way you are trying to maximize disc removal. Once you have removed maximally the disc, see actually you can see, I can use the drill also to remove the extra piece of bone if you want here. Very comfortably you can use. Sometimes what happens, the lip of the disc is hanging like this. You cannot put your instruments there. You can widen it by using a nice drill. And then what you do is, once you are confirmed that the disc space is good, you put a lot of bone. all the bones that you have taken out from the facet and from the lamina and the SAP, all that can be packed there. If you want a little more bone, you can take some autologous bone and you can use either a funnel or, under microscope you can use it very nicely. Then you have done a trial for the size of the cage. You can use different kinds of cages, banana cage, bullet cage, 1 cage, 2 cages, whatever you think is good. And then you place a place of hemostat, sponge stand or something, and that concludes the decompression part. So once that is done, you place the screws. Now screw placement can be done in a high-tech way if you have O-arm. Of course institutes have, but if you are working in a periphery or in a place where you don't have O-arm, C-arm guidance is sufficient. Even if you have C-arm difficulty or is not working, you can still place the screws very, very comfortably by understanding the anatomy, because you have exposed the pedicle inferiorly. You have to expose the transverse process superiorly on the same side, and you can place the screw under the microscope, under vision. On the opposite side, it can be done with 1 or 2 sorts of C-arm. So here, of course, you are using a navigated pedicle access kit with O-arm guidance, and then you place those wires, and then it becomes very routine to place those screw in position. And this is important to understand that you can, different sets are there available, the company people will support you. You can tighten the screw, you can mobilize the screw to such an extent, or you can pull it, and I can show you a rocking technique which I have described, where if there's a listhesis, you can pull back the vertebra. All those can be done. In the next talk I will be able to do that, and you get a good compression. So most patients can be mobilized the same day. Sometimes, if they have got significant pain, you can do it in 24 hours. One trick you can do is, when you are coming out, you can put some local anesthetic, sensor cane, into the muscle, so the patient can be very comfortable during the post-op period. So pain modulation that you need to do is very important. So I think this is the basics of the step-by-step approach to TLIF. You can do at 1 level, you can do at 2 level, you can do at multiple levels, depending on what equipment you have, and you can do multi-level fixations, you can do degenerative lumbar scoliosis correction. Those are all step by step. You can also nowadays put iliac screws. If you think that the support that you get at the S1 is insufficient, you can even put iliac screws and then connect it in a minimal access way. I think with that I'm going to stop. If there are any questions, please do not hesitate to ask. Yes, please.
Sir, you do the bony work first and then place the screws. Any specific reason?
So, I am a neurosurgeon like Professor Park. I like to make sure that I have enough space for decompression. Some people use they place all the instrument first, and then what happens is the head of the screw can sometimes come in the way of where you have to chop the SAP, and it becomes difficult. Another thing you noticed, I don't like to unnecessarily distract or compress the spine. Only if necessary you should do it. By doing this decompression first, all the anatomy that is virgin is seen completely first. It has worked out well with me.
Yeah, Dr. Surya, just a minute.
So do you believe in indirect decompression for all the cases, or in patients with the ligament of lamina?
Indirect decompression is a concept where you can use it if you have basically posterior ligament. If there is a bony compression, let's say there is a huge facet pressing on the nerve root, or if there is a bony compression somewhere like an osteophyte, indirect decompression is not a good idea. Indirect decompression works when there is ligamental compression. So when you stretch the ligament, the compression goes off. So indirect decompression is a useful tool if you know where the anatomical constraint is.
Sir, in case of single level discectomy, is it actually needed to place the screw to do the fixation?
I'm sorry, what is the question?
Sir, in case of single level discectomy, is it actually needed to do the fixation to put the particular screw?
No, I think there is a confusion in your mind whether in all patients of discectomy do we end up fusion. No. When you are doing a single level pure discectomy, you should not do facetectomy. I think you should understand that. You will do facetectomy when you are planned for a fusion procedure. So let me explain again for those who may not understand what I was trying to tell. Patients who have come only with radiculopathy and no listhesis. You understand this point? Patients with radiculopathy with or without listhesis will not require fusion in most instances. Therefore, don't plan for a fusion in all discectomy patients who require discectomy. Patients who require fusion should have failed conservative therapy for long-standing back pain. Can anybody tell me what is long-standing back pain? 6 months. At least 6 months of back pain. I mean, these are all caveats there. For example, if somebody has a disease and a back pain, they don't come under the degenerative classification. For somebody to say it's a degenerative disc disease and that is causing back pain significant enough to get surgery, you must have this point very clear. They should have had back pain for at least a few months, should have failed conservative therapy. What is conservative therapy failure? 4 to 6 weeks of physiotherapy, analgesics, physical therapy other than just going to the physical therapy, etc., etc. If they have failed all those, then only do they get the plan for fusion. I hope I made this point clear to you.
Yeah, and what about the grade 1 listhesis? Same true or?
So grade 1 listhesis is in young people I tend to fuse, young meaning 30s, 40s, or if they have significant back pain. Elderly people above 65, 70, grade 1 listhesis, you can just get away with the decompression.
Yeah. Yes. Yeah. Mike?
Sir, for microdiscectomies alone, which is better, sir, endoscopic or tubular MIS?
So, I am a tube man, so I use tubes for anything, everything. So I'll tell you how I planned my lung surgery was when we started doing spine surgery in early 90s, and you start doing only that and you see foramen in every patient. So please, you understand what I'm saying. You please learn UBE because that's the thing of the future. UBE just started doing fusion at one level, multiple levels. So that's going to take over a lot of surgery that a tube doctor used to do. But I want you to understand the principle. Whatever technique you learn, it should serve you in multiple ways in multiple levels.